welcome to Tea Time with Lorna. Now, what did you do this weekend? As for me, I had a great weekend. I was in New York, again, one of my favorite cities in the world. I had a great time, hung out with friends. I actually did a little bit of work on a film, so that was great. So I hope you all had a great time and a great weekend. Today, I'm visiting with a friend of mine who happens to also be a doctor. I decided to have tea with him today just so that I could squeeze some knowledge out of him about just a couple of health issues that's going on in the world today and see his take on things. So I'm very grateful to have Dr. Garth Oliver with me today. Thank you for joining me.
My pleasure.
Good morning, or good afternoon rather. Anyway, so before we get started, let's talk tea. So what tea have you decided to have today?
See, I recognized the Earl Grey, so I immediately wanted that, but I think I'm going to try something new with the coconut mango.
Okay, please do. I am going to go with a perfect peach, and I'm going to have that. So we are going to enjoy our tea while we talk. So, I'm going to call you Garth because I know you. I'm not going to call you Dr. Oliver. I hope you're okay with that. So tell me, one of the things that I know that I learnt about when I was in school, in college, was just basic screening for health. But what does that mean? What does that really mean? I mean, I want to be screened, or should I be screened? I don't want to be screened. What's the deal? I think I'm fine. Should I be screened? Go ahead, tell me. What's the deal with screening?
So screening is based on population risk.
Okay.
So every population, whether it's, say, female is a population, a subpopulation, a woman should be screened for things that men don't have to be screened for, and vice versa. So every population or subpopulation have certain risk. So for example, if you are a man of color, you have certain risks that are different than men of, say, Asian descent, or men who are Caucasian. So men of color need to be screened for things like prostate issues, prostate illnesses. Women, as you know, have to be after a certain age or based on family history, have to be screened for things like breast cancer, early breast cancer, so they get mammograms. So screening is huge because different populations, based on genetics, based on environmental exposures, and even based on lifestyle, have risk. Okay. So, for example, in this country, 44,000 or so people are dying on a regular basis. I think they said every day, but if you think about, that's from a song.
Wait, are people dying on an irregular basis?
They do. Actually, that is true.
What does that mean?
Well, around the millennium, they found out that there was a surge of people dying in January of 2000 because apparently they had held on to see sort of what would become of the world after Y2K.
Oh,
so that's
okay.
a sort of irregular death rate. There was a surge in deaths. It's true.
Okay, I didn't know
and
that.
so you look at what kills people. People die of natural causes. Dying is natural. Let me say that as a doctor. Just because somebody died doesn't mean somebody failed. But dying is completely natural. But of preventable causes of people dying before their life expectancy, you look at what kills people and you see number one is still heart disease in this country, and then number two is going to be cancers. And then you say, you know, is there a way we can prevent heart disease, or at least make it not so aggressive, or at least make it not so kill such young people? And then, so screening comes into looking for heart disease, some of the risk factors for it, looking for cancers and the risk factors for it. So that's what screening is about, is looking for something that you as a subpopulation are at risk for. Okay,
so what about things like, because I don't know if you know this, but in my prior life, not that long ago, I worked as an EMT, and I was blessed to be able to work in the emergency room. Yeah. Now, what about things like, and maybe this doesn't come under screening, maybe it does, what about things like men coming into the ER and they're not looking at them as heart attacks, they're looking at other things first before they come to that? Would that be considered screening, or is that not screening? I don't know.
That's an interesting point. I mean, there is such a thing as diagnosing symptoms.
Okay.
So the idea of screening is pre-symptoms. Okay. So long before a person and this is why I think screening, this is a passion of mine, why I think screening is so important to talk about, is because there are cultures of people who said, oh, you don't go to the doctor unless you're feeling sick. Okay. And there are people who believe it's a waste of precious time to go see a doctor when you're feeling fine. And that's wrong-headed in the sense that screening insists that, look, if you're a part of a population, say a woman over 40 or a man over 50, please go have your prostate looked at. Please have your colon looked at, because long before you feel anything, you may be showing signs of the disease.
Okay.
So heart disease shows up usually before a heart attack. In fact, I'm being facetious there. It always has some telltale sign before. So we call something an event, like a heart attack is an event.
Okay.
Or a stroke is an event.
Okay.
But long before the stroke or the heart attack, there are little things that
warning
you can
signs.
find. Yeah. Not just warning signs to the patient, but things that you can look at to say, hey, did you know that you are at increased risk for a heart attack or increased risk for a stroke or increased risk for prostate cancer long before the patient discovers it or has symptoms?
So is this one of the reasons why, and I think I know the answer to this, is this one of the reasons why it's a good idea to get an EKG? Because then, as far as heart attacks is concerned, because then you have a baseline. You have a baseline of something. In other words, maybe the person's normal.
Yeah.
This is your normal level. And then maybe in, 4 years' time, I don't know, you go back and it's different?
Yes.
Okay.
So the short answer to that is yes. The
Okay.
long answer is no.
Okay.
Let me say, the short answer is absolutely. In fact,
Okay.
I strongly believe in that. I believe in getting a baseline EKG around the time of 40 or even before, for people who are going into school athletics, for example.
Okay.
When they're nice and healthy. Most of the people who faint or pass out on the court are not dying from classic heart disease. They'll pass out from arrhythmias, meaning the heart's beating in a funny way. Yes, exactly.
Okay.
And they can't sustain blood flow to their head, so they'll pass out.
Okay.
And so, yeah, that's a requirement that we get an EKG on just about all athletes. But
Of any age? Are we talking any age?
pretty much. Once they're in competitive sports, one recommendation. By the way, this goes into pediatrics, so I'm not going to say too much about this. There
Okay.
are guidelines for how we should be screening pediatric populations before they go into sports. But I do know by the time they reach, so I treat people 18 and older, by the time they reach my office, I screen everyone for cardiac arrhythmias and so on before I okay them for sports. Yes.
Okay.
So, but the reason I said no is the long answer is an EKG in and of itself has a very low what's called a positive predictive value. An EKG tells you what may have happened,
But also
and what's happening at the moment, but it doesn't tell you a lot about what
the
will
future.
happen. Yes.
Okay. Unless
Whereas exercise stress tests might tell you what will happen over the next 12 months.
okay, unless you happen to see something irregular
At the moment.
at the moment on the EKGs,
Right.
then that can be the predictor of
Exactly.
future.
And we call that a
event.
resting EKG.
Okay.
So somebody just laying there and you're recording 10 seconds of their heart's history doesn't predict a lot. It'll tell you if they've damaged it or if they have an ongoing arrhythmia. Right. But it doesn't predict how that person is going to do with mild to moderate exercise.
What can we do? What can we, when I say we, I mean the people in America, or since we're talking about heart attacks in this country, so we'll just leave it here. What can they do? Here, drink your tea, please, please. What can people do? Obviously, there's screening, right? What else can they do to, as far as screening is concerned? You go, you get an EKG.
Yes.
What else would you suggest in the screening process?
So, hand in hand with screening is something I want to touch on later on, which is lifestyle modification, which has more prevention in it. So I kind of hear your question going to that. But in terms of screening, so just to cheat, in my office, right over there on that wall, it says actually Adult Preventative Care Timeline.
Okay.
And so what it does is it gives I don't know if you want to get a shot of that later, but it gives us exactly what should be done, like who should be screened for certain things.
Okay.
Because not everyone is at risk. So the things that can be screened for in women's health is if a woman is sexually active, she should get pap smears with some regularity. If her last 3 pap smears are negative, she doesn't have to go every year. If she's with the same partner, she definitely doesn't have to go every year. In conjunction with her gynecologist, she can go once every 2 years or once every 3 years. So if you have a 50-year-old married woman who's been married for 30 years and has shown no signs of it's called cervical dysplasia or any irregularity in her pap smear, she doesn't have to go every year.
Now, what about, let me ask you this. Maybe, I don't know if this is preventative, maybe it is, maybe it isn't. What about HPV? Have I got it,
Yes,
have I got it right?
yes. Yes, you're right.
They're running around injecting everybody. Are they giving it to us? Are we giving it back? What is going on? Because when that needle goes in, what's in there and what's coming out? That's what I want to know. I don't want it, and I also don't want to give it to anybody.
So that's a great question. And here's the
the
problem with the HPV vaccine.
Okay.
There's so much politics around it.
Yes.
So now, just because politics got involved with something does not mean it's a political issue.
Okay.
Politics tends to seep into every crevice of our lives.
Okay.
And so here's my HPV. There's even some controversy now about, look, it mostly affects women.
Okay, so why are we giving it to boys? Why are we giving
That's
it to
a great point.
I'm sorry.
That's a great point. No,
This is a question. I
I
just
love
wanna
it
know.
when people are passionate about it.
Go ahead, why are we giving it to boys? When I say giving it, I mean the
They're the perpetrators. They're the disseminators of HPV.
Meaning?
They are the ones. So when a woman gets HPV, she's getting it from a man.
Aha.
Mm.
Men, once again, guilty. Guilty. Not even by association. Just pure out guilty. Drink it
By
tea.
injection, right?
It's guilty.
But here's the thing. The sad truth is there are about 80 different serotypes of human papillomavirus.
80?
Yeah, 80.
80?
Yeah. So there's serotype 1, 2, 3, 4, 5, 6,
To
7,
80.
to 80.
So
Yes.
is the injection got 80 strains of something?
No.
Well, what the
Great, another great question.
79?
But
It's got one? Listen, I'm not getting
so
it.
there are
I'm out.
about 3 strains that have been strongly associated with causing the cancer.
Okay.
So like subtypes 18, subtypes 30, 31, those have been associated. So if the 80 serotype, by the way, the last time you get a wart on your hand or something, that's a form of HPV.
I've never had a wart.
So yeah, so they're in fact most human papillomavirus when they hit you somewhere are completely benign.
Okay.
All right, and they cause no cancer. However, 3 out of the 80 subtypes, so if you do the math, that's 1 in 27 or about 3%, or 4%.
Drink your tea. Go ahead.
About a certain percentage of them will cause cervical cancer. And thank God it's a slow progressing cancer. So it's not a very aggressive cancer. So if you do get screened, you can spot it. Like you can see 1 year, and then you don't have to wait a full year. You can go back 6 months, and if it seems to be progressing, then you decide to do a procedure that cuts out the affected area of the cervix. Now, here's the thing. The sooner a woman starts becoming sexually active, having unprotected sex with men, she never knows which man has HPV because it doesn't seem to affect the men.
So we're giving them the preventative injection, even though they don't know they've got it, to stop them from giving it to a woman.
Right. And so, you know, the
Right?
studies that are missing. Right.
Okay.
So here's where it gets political.
The studies that are missing?
The studies that are missing is we don't know what percentage of men are, I don't know what percentage of men are carriers. I don't
Okay.
know that study has been done.
Okay.
I mean, maybe I could go and research it, but
That's all right.
we don't know what percentage of men actually have. So when we give it to all men, we're assuming there's this concept of there's a number needed to treat to prevent that. So when we find out that a man is a carrier, which we don't do, we're just saying, no, give every man. Whether he has one partner, multiple partners, or whether he's celibate, let's just give it to every man. And so you're missing a lot. The part that bothers me and a few other people are noticing is they're having different recommendations for different communities.
Okay.
So if
because
it's,
I read somewhere
Go on.
that boys at 11 are getting this?
boys at 11 where? So they weren't
Okay,
actually...
I didn't notice that.
Right.
Go ahead.
So for places in Washington, D.C. that have a certain kind of population...
You can say the word, because I don't know what that means.
Washington, D.C.?
No,
That's the capital of the...
No, I know what Washington is. When you say certain population, what is that population?
So poor,
you
more
can say the
brown
words.
people.
Okay.
They're being recommended to be doing it much sooner. So you
Sooner
have
than
them
11?
They're having, 10, 11. Some of the girls are being vaccinated way preteen.
Okay.
Whereas in other cultures where other parts of the same country where they believe there's less promiscuity, and again, this is where it's like not backed up by data but by prejudices. Thinking, these people are less promiscuous, we can start giving it to them at 13. And so just the mere fact that some populations,
yes,
without the data. Now, if there's data that suggests that little girls of color are more sexually active starting as early as 9 and 10, and then you say we have to vaccinate, because you have to vaccinate them before they're exposed. So if you have data for that, then sure, then you could show and say, here's the data, this is why we're suggesting, women or girls of color get started 2, 3, 4 years sooner than another population.
So who can I call to find out if data's been doing? Who am I calling?
Well, what's really sad about that is
CDC?
that almost anyone now can come up with recommendations.
Oh my God.
So that's in flux, meaning there's no one settled on it. And by the way, this is a similar controversy that surrounded even breast cancer screening. I think it's universally accepted that women should get breast cancer screening. But at one time when the U.S. government, they have a task force, they were suggesting 50 and over. And then you had the American Cancer Society saying, no, 40 and over.
Okay.
So the fact that there's controversy is not the controversy. The fact, though, that there are, sort of racial disparities in the recommendations without data, that's the real controversy.
Well, I actually did research for my graduate school on breast cancer. And one of the things I found was that they felt that preventativeness in the African American community would not actually lower the risk of breast cancer in the African American community.
Great point. Wow, I'm impressed with you knowing that. I do ask my patients, who has a higher incidence of breast cancer in this country, a woman of color or a woman of Caucasian descent?
And I know the answer to that.
Do you?
Yes.
Let's hear it.
It's a woman of color. And when they get the breast cancer, it is at a later stage, usually stage 3 or 4.
Yes.
And it's the more aggressive type of breast
cancer.
cancer.
What I am going to say to you is that's true, except I have to redefine one little word.
Go ahead.
So there's a difference between incidence and death rate.
Yes.
So the incidence is actually higher among Caucasian women.
But the death rate
is higher among women
African,
of color.
Yes.
And
that I knew.
That is because of screening or lack of screening.
Yes. But also what I found interesting, because like I said, I happened to do research on this because I actually did research on this for Sloan Memorial Kettering Hospital. That's who I did my research. Yeah, that's who I did my research for for graduate school. But anyway, was the number of women from like the South Pacific and Native Americans and from China, Japan, and those women who had such low incidence incidence and death rates and all of that across the board.
Right.
And it's like, well, what are they doing? What are they doing that the rest of us
that's a great point.
is not doing? Because to me, I'm not an expert, but that's who we should be following. Because if they're not getting it, well then what are they doing? Am I wrong?
So that's a combination. What you're picking up on is a combination of genetics and environment.
Okay.
A fascinating study I came across was Japanese women have a much lower risk for breast cancer than American women.
Yes.
Much lower. Like there's a huge
Yes,
gap.
I probably read that one too.
Yeah. When these Japanese women moved to Hawaii, a little
Their
more American
incidence-
their incidence went up, but still not as much as it's happening in America. So clearly their genetics didn't change by moving to Hawaii. So you can't just attribute it completely to genetics. However, and by the way, a lot of people tend to eat the way they still do from their native. So, we would assume there's Japanese women are still eating sort of Japanese food, whether it's more fish-based. Because we know, for example, a lot of our stock animals, chicken, America's gone from eating about 9 pounds of chicken a year, pre-World War II, to somewhere in the neighborhood of 57 pounds a week now. That's over a pound.
Wait, each person?
Yes, individually.
Is eating 9 pounds of chicken?
Was eating 9 pounds of chicken annually.
And now we're doing 57?
Now we're doing closer to 57, which is more than a pound of chicken per week. Somewhere along the line, we get the idea that that was a great thing.
It's not a great thing?
It's not a great thing because a lot of our farm-raised chicken are, jacked up with estrogen. And we know that more than half of our breast cancers are estrogen receptor positive, meaning they grow faster under the influence of estrogen.
Okay, a different question.
Now, if this is going to be broadcasted, I need to caveat that with a lot of things because I'm not Oprah. I can't afford to get Oprah said, there's clear evidence. I don't have Oprah's money, nor her audience, but there's clear evidence that the amount of animal fat we're taking in is directly associated with a lot of the cancers that we're fighting.
Okay, different question, but kind of similar, but kind of not similar. Do you know anything about why there's a higher incident, one of the highest incidents of cancer, because that's our second leading cause of death, why there's such a high incidence in Long Island and Stanford and Greenwich and Darien? Do you know why?
So that is strictly environmental. So that's called cancer clusters, and the CDC pays people handsomely, more than I make, to sort of decode why they're cancer clusters. And it's really interesting because, again, politics has creeped into this. So even when they're noticing cancer clusters, and by the way, the neighborhoods you just described are middle to upper scale, neighborhoods. So some of this is not as publicized because that would tank real estate markets and so on. I'm not even making this up. There are cancer clusters that have been sort of squashed and like, oh, no, there's no cancer. These are not those clusters you're looking for. The sort of Jedi mind trick. There's no cancer cluster here in our median income of, $1 million homes.
Maybe I shouldn't have said it either.
So you gotta be careful now, because but yeah, there are cancer clusters.
I'm not Oprah,
and
I never claimed to be. I don't have any money either. I just do research. I'm sorry if I can read. And I went to school. I'm sorry.
Yes, you have to cite your site to protect yourself. Yeah. Well, I read in the so-and-so journal.
Exactly, I read it somewhere.
Well, yes, in this country, this great country we live in, there have been places that are just drenched with, they're called Superfund sites, and even that was political. So there are areas where we used to manufacture things. By the way, one of the most polluting things for the soil used to be laundromats.
Really?
It's really weird.
Laundromats as in the laundry?
No, not our current laundromats, where they used to actually wash people's clothes and open bins of these solutions and then they'd pour them in.
Back
apparently that, yeah. And so, yes, about maybe 2-3 generations ago, there were sites that super contaminated the soil and contaminated the environment, and so the plants that grow there now, and even when people are drinking well water from somewhere, I have places that are not that many blocks from where I live where people are still drinking well water and pumping, and they, there's this notion that it's coming naturally from the ground, so it must be better. And yes, and exactly. And so if you are downstream in the water table from a factory that wasn't as well regulated, say pre-World War II, and by the way, there's still places in this country where the regulations are much, much more lax. That's why the federal government tries to set standards for anywhere you live in America, but you'll have a state like, for example, Texas, that has very different regulations about how you dispose of waste, and that's very different from, say, Connecticut about how you dispose of waste. For example, this area, the whole Hudson Valley, up and down the Connecticut River, used to be huge industrial complexes. World War II, I remember hearing some interesting statistic about Connecticut about what percentage of all the equipment was made here in the Northeast. And so there are lots of factors up and down these rivers, and so downstream they're measuring still high levels of dioxin, and as silt comes over the years it sort of buries things. But every now and then they'll say, this waterway is sort of getting shallow, we have to dredge it for barge movement, and they dig up everything, and the next thing there's all this dioxin. Yeah.
So let me ask you a different question, completely different, because that was a lot of information, but thank you for sharing. When you have a moment to breathe, when you're not seeing patients, when you're not doing research and reading and keeping up with all that's going on in the medical community, what do? Because I know that you like to drum.
I do. Oh, I love drumming. In fact, it's so funny. I heard something recently about people who do things like that. It helps to actually structurize the brain. So even here in my office, I actually have a drum pad so for those patients who will tolerate it, even while I'm thinking, those who know me, I just start drumming. Something about the pattern.
Okay.
I just start drumming. It helps me think.
Did you ever play like in a marching band?
No, but I do play the drum kit for like a music band. I play for different things, for church usually, and I try to keep the rock element down so as not to upset your average senior congregant. But I love drumming. I have a kit at home. It's my therapy room. Sometimes I go home, I greet my family, and then I go sit. I have this sort of outside office, and I just go sit there, and my neighbors have to put up with me wailing like a 30-minute drum solo, just getting it all out. And then I'm more, user-friendly.
Okay, excellent. We are running out of time, but I want to ask you this.
Sure.
I want to ask you a little bit about preventative stuff.
Sure.
Tell me a little bit of preventative stuff. We didn't really catch on it, but I want to hear some stuff.
I hate the fact that it's called prevention because it's health. I use the term, but I call it lifestyle modifications.
Okay.
Or just lifestyle choices. There are people who just live a certain way that is healthier. They eat what they like to eat is better than what we like to eat. And maybe it's just what's available. For example, the Mediterranean diet. It's not called the Mediterranean diet because it was derived from experimentation. It's called the Mediterranean diet because that's what the people around the Mediterranean eat.
And that's mostly a diet that is
plant-based and fish protein.
Fish, a lot of cheese, tomatoes, and oil.
A lot of extra virgin cold-pressed olive oil.
Okay.
They drink the equivalent of a quarter cup of olive oil a day.
Now, why?
Because it's in everything. They just put it on everything. They don't just drink it straight. No.
Okay.
They pour olive oil. They cook with it. And it doesn't remain virgin after you cook with it, but they consume a lot of it. And it's been shown to be in terms of a regional diet, it's really been called the healthiest diet in the world. And some of it was out of necessity. We find that a lot of the richer foods we eat require a lot of energy and money and so on to go into, raising cattle and so on. Catching fish is relatively cheap in comparison to raising, 1,000-pound steer. But just because we have all this food available in this country doesn't mean we should be consuming it at the rate we do. We actually, in this country, consume about 40% of the world's calories. We're number one.
Wow.
We're pretty good at that. So preventative, as you're calling it, or lifestyle choices, has to do with basically diet and exercise. That's mostly it. And of course, avoiding bad habits like cigarette smoking and
the usual
shooting up anything into your veins.
This is good. Okay, one last question. If you can, share with me and whoever's watching today, if you had an opportunity to have tea with anyone, obviously still alive, because how is that going to work? If you had an opportunity to have tea with someone, who would your person be?
One person. Real quick, I would probably say Elon Musk at this point.
Okay.
I was going to say Barack Obama. Since I'm allowed one person, I won't say. And the reason is, in my lifetime, to see individuals who have a vision for changing the world, both of these guys are doing that in my lifetime. They're great people who have lived before that I would love to have tea with. But in my lifetime, to see people who are not necessarily full of years, in relative youth, just have a vision for how different things can be, whether it's in transportation with Elon Musk or whether it's in politics and just social interactions through Barack Obama, our former president, I would just love to meet with someone like that. I think they've already changed the world, and their vision is going to continue to change the world.
Well, thank you very much. I really appreciated that. Well, we don't really have much time for anything else, but I really appreciated you. We didn't have to shake hands with friends, but that's okay. I really appreciated you joining me for tea today. This was great. I just hope that people that are watching got a little something from today's episode. Let's go and get your screenings. Go and do your preventative stuff. Go do something. Doing something to take care of your health is better than doing nothing. That's what I got out of this. Exercise, change your diet. Let's all get into the Mediterranean diet. And then we should go to the Mediterranean. Don't you think? Let's go to the Mediterranean.
Beautiful.
You see, this sounds like a great plan. I'm already loving it. So you go to the Mediterranean after you've done the Mediterranean diet. I think this is a great plan. I feel like this is going to work. Anyway, so thank you for joining me today. So that's literally all we have time for. I had a great time meeting with Dr. Oliver, I call him a doctor now, and love discussing these things. Health is one of my favorite topics. I love to look into research. I love to talk about heart disease, cancer, Alzheimer's, diabetes, hypertension, all of those things. They all fascinate me. I'm always interested in who gets it, who doesn't get it, and why they got it, and why they didn't get it, and how they can get rid of it. That's kind of the short version. That's my medicalness in a nutshell. So thanks for joining me today at Tea Time with Lorna. Always here on Local Access TV. I hope you're enjoying the show, and I hope I see you next week. You can also subscribe to the YouTube channel. Anyway, that's all we have time for. Thanks for tuning in. Bye.